Everyone, welcome to our session today, which is a key component of our anatomy education series. I am Dr. Ahmed, and today we are embarking on a detailed journey through the thorax and mediastinum. This presentation is designed as a comprehensive illustrated guide to help you master the complexities of the bony thoracic wall and the intricate subdivisions of the mediastinal compartments. Over the next 9 minutes, we will bridge the gap between basic skeletal structure and the critical internal organization of the chest. Our focus will remain on the structural logic that allows this region to protect vital organs while facilitating the mechanical process of breathing. Let us begin by defining our area of study. To start our introduction, the thorax is the vital region of the body situated precisely between the neck and the abdomen. Anatomically, it is defined by its enclosure, a protective bony cage formed by 12 pairs of ribs and 12 thoracic vertebrae. This cage is not merely a static shield, it is a dynamic structure. Within its boundaries lie the essential organs of respiration and circulation, specifically the lungs, the heart, and the thymus gland. Consequently, the thoracic cage plays a centralized role in three fundamental physiological processes: the protection of viscera, the mechanical movement required for respiration, and the accommodation of the circulatory system's primary pump. Understanding its boundaries is the first step in clinical diagnosis. Overview of the bones of the thoracic wall, we can categorize the framework into 6 primary components. First, we have the 12 pairs of ribs, which provide the lateral curvature. Second is the sternum, composed of the manubrium, the body, and the xiphoid process. Third, we look at the posterior support, the thoracic vertebral column with its 12 vertebrae. Fourth, we must distinguish between rib types, specifically true ribs 1 through 7, false ribs 8 through 10, and floating ribs 11 and 12. Fifth, we will discuss the sternal angle and its immense anatomical significance as a surface landmark. Finally, we will touch upon the various joints that allow the thoracic wall to expand and contract during the respiratory cycle. Moving into the general classification of the ribs, the 12 pairs are grouped based on their anterior attachment to the sternum. The true ribs, pairs 1 through 7, attach directly to the sternum via their own individual costal cartilages. Below them, the false ribs, pairs 8 through 10, attach indirectly. Their cartilages actually fuse with the cartilage of rib 7. Finally, we have the floating ribs, pairs 11 and 12. These have no anterior attachment at all and end freely within the abdominal wall musculature. It is a critical clinical note that because these floating ribs lack anterior cartilage support, they are significantly more vulnerable to fracture from lateral trauma, as they cannot distribute force as effectively as the upper ribs. Let's examine the structure of typical ribs, specifically ribs 3 through 9, which share a common pattern. The head of the rib features facets that articulate with the bodies of 2 adjacent thoracic vertebrae. The neck is the narrow segment connecting the head to the tubercle. The tubercle itself articulates with the transverse process of the corresponding vertebra. The main part of the bone is the body or shaft, which is long, thin, and curved. A vital feature for clinicians is the costal or subcostal groove. This runs along the inner lower border of the rib and serves as a protected channel for the intercostal vein, artery, and nerve. This arrangement is key to understanding the 2 articulation points, the costovertebral and costotransverse joints. We must differentiate the atypical ribs, namely ribs 1, 2, 10, 11, and 12, which depart from the typical pattern. Rib 1 is notably short and flattened, characterized by grooves for the subclavian artery. Rib 2 is longer and features a prominent muscular tubercle for the serratus anterior muscle. Rib 10 is unique because it possesses only a single facet to articulate with its own vertebral body, rather than 2. Ribs 11 and 12 are both short and lack a neck and a tubercle entirely. Rib 12 is the shortest of all, resembling rib 11 and classified as a floating rib. Recognizing these variations is essential for identifying specific ribs on an X-ray or during surgical procedures in the thoracic cavity. The sternum, often called the breastbone, consists of 3 distinct parts. The upper part is the manubrium, which articulates with the clavicles and the first 2 ribs. Below it is the body, or corpus, which is the longest central part and articulates with the costal cartilages of ribs 2 through 7. At the very bottom is the xiphoid process, a small cartilaginous tip. A landmark of paramount importance is the sternal angle, or the angle of Louis. Located at the junction of the manubrium and the body, it marks the articulation of the second rib and lies level with the T4 vertebra. It is one of the most important palpable landmarks in surface anatomy, used to count ribs and locate the heart's valves. Turning to the posterior aspect, the thoracic vertebral column consists of 12 vertebrae. These are easily identified by their distinctive heart-shaped bodies. Each vertebra articulates with ribs on both sides through specialized costal facets located on the vertebral bodies and the transverse processes. This structural integration allows the vertebrae and ribs to form the posterior wall of the thoracic cage, effectively protecting the spinal cord and the posterior thoracic viscera. The arrangement of these facets dictates the range of motion in the thoracic spine, which is more limited than in the cervical or lumbar regions to ensure the stability of the chest cavity and the protection of the delicate organs housed within. The spaces between the ribs are occupied by the intercostal muscles and the neurovascular bundle. There are three layers of muscle: the external, internal, and innermost intercostals. The external fibers run downward and forward, while the internal fibers run downward and backward, deep to the external layer. The innermost layer is the deepest and is closely applied to the pleura. Crucially, the neurovascular bundle, often remembered by the acronym VAN, standing for vein, artery, and nerve, travels within the costal groove. It is situated between the internal and innermost muscle layers. When performing procedures like a thoracocentesis, it is vital to remember this superior to inferior order and to always insert instruments above the rib to avoid damaging these structures. Transitioning to part 2 of our presentation, we focus on the mediastinum. The mediastinum is the central compartment of the thoracic cavity, situated between the right and left pleural sacs that contain the lungs. It is a highly crowded and vital space. It extends vertically from the thoracic inlet superiorly down to the diaphragm inferiorly. Anteriorly, it is bounded by the sternum and posteriorly by the thoracic vertebral column. This central corridor houses almost all the vital thoracic organs except for the lungs themselves. This includes the heart, the great vessels, the esophagus, and the trachea. Understanding the organization of this space is the cornerstone of thoracic surgery and radiology. To make the study of the mediastinum manageable, we divide it into specific subdivisions. These are the superior mediastinum and the three parts of the inferior mediastinum: the anterior, middle, and posterior mediastinum. Each of these subdivisions has specific anatomical boundaries and contains unique structures. In the coming slides, we will break down the boundaries for each subdivision and list the key contents found within them. This systematic approach allows clinicians to localize pathology based on its position within these imaginary but anatomically significant borders. We will start with the superior region and work our way through the inferior compartments, ensuring we cover the anatomical landmarks that define their limit. The superior mediastinum is defined as the space extending from the thoracic inlet down to the level of the sternal angle at the T4 vertebral level. It is a busy junction for vessels and airways. Key contents include the superior vena cava and the azygos vein. Most importantly, it houses the aortic arch and its three primary branches: the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. Additionally, the upper portions of the trachea and the esophagus pass through this compartment as they descend from the neck into the chest. The nerves traversing this area, such as the phrenic and vagus nerves, are also critical structures that pass through this superior gateway. Next is the anterior mediastinum, which is the smallest of the four subdivisions. It is located between the sternum anteriorly and the pericardium posteriorly, extending from the level of the sternal angle down to the diaphragm. Its contents vary significantly with age. The primary structure here is the thymus gland, which is largest in children and undergoes involution after puberty, being replaced by fat. Other contents include loose areolar and fatty connective tissue, the anterior mediastinal lymph nodes, and branches of the internal thoracic or mammary artery. While small, this space is significant because it can be a site for thymic tumors or lymphadenopathy in clinical practice. The middle mediastinum is arguably the most important compartment of the thoracic cavity because it contains the heart, which is enclosed and protected by the fibrous pericardium. Beyond the heart itself, it contains the tracheal bifurcation into the right and left main bronchi. Note the anatomical difference. The right main bronchus is shorter, wider, and more vertical, while the left is longer, narrower, and more horizontal. Together, these structures form the body's primary respiratory and circulatory axis. Because it contains the heart and the origins of the great vessels, any pathology in the middle mediastinum is typically life-threatening and requires immediate clinical attention. Finally, we have the posterior mediastinum. This compartment is situated between the pericardium and the T5 through T12 vertebral bodies. It serves as a major thoroughfare for structures moving between the thorax and the abdomen. The esophagus descends here, located posterior to the trachea. To the left of the vertebral column, we find the descending thoracic aorta. This space also contains the thoracic duct, which drains lymph into the left subclavian vein and the azygos and hemiazygos veins. Furthermore, The greater and lesser splenic nerves pass through this region on their way to the abdominal viscera. The posterior mediastinum is a deep space that requires careful study in thoracic imaging. To summarize our first section, the complete thoracic cage is an integrated bony framework. It consists of the 12 pairs of ribs, classified as true, false, and floating, the 3-part sternum, and the 12 posterior thoracic vertebrae. This architecture is a masterpiece of biological engineering. The true ribs articulate with the sternum anteriorly to provide stability, while all 12 pairs articulate with the vertebrae posteriorly to allow for the expansion needed for breathing. The resulting structure is simultaneously strong enough to shield the heart and lungs from impact, yet flexible enough to accommodate the constant rhythmic movements of the respiratory cycle throughout a person's entire life. To provide a spatial summary, let's look at the organ distribution in the mediastinum. The heart and pericardium reside in the middle. The thymus is anterior. The esophagus and descending thoracic aorta are tucked away in the posterior compartment. The superior vena cava and the aortic arch are found in the superior subdivision. We also find the thoracic duct alongside the esophagus in the posterior region. It is also important to remember that certain structures, like the vagus and phrenic nerves, are not confined to a single space. They traverse multiple mediastinal subdivisions to reach their targets. This cross-sectional logic is what clinicians use to build a mental map of the patient's internal anatomy. It includes our comprehensive overview of the thorax and the mediastinum. We have covered the bony landmarks, the muscular and neurovascular organization of the chest wall, and the complex internal subdivisions of the mediastinal cavity. I hope this guide serves as a solid foundation for your continued studies in clinical anatomy and radiology. At this time, I would like to thank you for your attention throughout this 9-minute session. I am now happy to open the floor for any questions or to discuss any specific anatomical points in further detail. Your feedback and discussion are highly welcome as we conclude this module of our anatomy education series. Thank you very much.